I'll be yourself. Mr. Nicky. With that mic.
Thank you. Okay, thank you, ladies and gentlemen. May I bid you all a good morning and welcome to everybody to this meeting of the Health Scrutiny Committee, which is now being live broadcast. Minutes of the last meeting held on the 12th of February. Can I accept these minutes of true and correct record, please? Show of hands. Thank you very much. James, do we have any apologies for absence, please?
Yes, Chairman. So we have received apologies from Dr. John Doddy for other reasons, Councillor Steve Carr for other reasons, Councillor Michelle Welsh for other reasons, but we have Councillor Henry substituting. Thank you, Chair.
Thank you. And we also have apologies from Sarah Collins, the Chair of Health.
Yes, we do. Yeah.
Thank you very much. Declarations of interest. Do any members present have a disclosable or pecuniary interest to declare, or do members have a private interest, pecuniary or non-pecuniary, to declare? Bethan?
Just to declare that I'm appointed governor at Nottinghamshire Healthcare Trust.
Thank you. Councillor Wilmot?
Just for noting that my daughter works for the NHS.
Okay, thank you for that. No other declarations? Right, okay, we'll move on to agenda item 4 now, please, which is a summary of independent maternity review feedback and CQC feedback and improvements made. And if you remember, we're going to consider a report from Nottingham University Hospitals NHS Foundation Trust, which was requested by this committee on the recent update on maternity services improvements last July. And I mean, it's a very topical subject at the moment, which we're all very well aware of in this county. And I'd like to invite representatives from the NUH, Anthony May, Chief Executive, welcome. Dr. Manjeet Jamar, I hope I pronounced that right, thank you very much, who is the Medical Director. Tracy Coulter, Chief Nurse, welcome. And Sharon Wallace, Director of Midwifery. Good morning. Good morning, very welcome. And thank you, Anthony, Tracy, Sharon, for coming along this morning. And so now open up for you to take on for discussion, please.
Thank you very much, Chairman. Morning, everybody. Thanks very much for the invite this morning, as well as colleagues that Roger's introduced. I've also got my colleague Robert Smith here, who's our Deputy Head of Service for Communications and Marketing. We've got a report for you that was published with the papers. My job is to draw out just a few of the highlights because the time is probably best spent with members asking questions so we can cover everything that's of interest to you. But just to start, the report covers two things broadly. The feedback that we've received from Donna Ockenden, who's the independent chair of the maternity review, which is currently underway in Nottinghamshire. It's accompanied by a police investigation, and I'm sure you're familiar with all of that. But of course, as we go through the session, we're happy to ask questions about any aspect of the review. The other aspect of this report is feedback from the CQC, either from reports that were published in 2023 from memory, or informal feedback that we received from inspections that were conducted in June and July last year, for which the official reports have yet to be published. We expect them to be published soon, but because we haven't got firm publication arrangements agreed with the CQC, we've given you some informal feedback from those inspections. And the report largely covers these areas: the governance of our maternity services, some of the feedback in relation to the cleanliness and the state of the environment in maternity services, the kindness and civility of our colleagues in maternity services and the way that we communicate with women and families, and an update on staffing, because staffing has been a major concern for us for a number of years, and we've spoken at length at this committee previously, so we've given you an update on staffing, both midwifery staffing, but also obstetric staffing as well. And of course, as you said, Chairman, our maternity services are very often featured in the local and national media, so equally very happy to answer any questions about things that you might have seen or read in the media recently. And before I go into the report itself, I should like to pay tribute to the families who have been extremely courageous in telling their stories in the media recently and engaging with the Independent Maternity Review. We are working with the families on a range of commitments that we gave to them at the Trust's annual public meeting last year. And as time goes on, as those commitments mature, we'd be very happy to come back and talk to you about those. I should also like to pay tribute to the staff who work in the services. They work extremely hard. The report, as you can see, paints a picture broadly of improvement. The improvement, of course, is entirely down to the hard work of the staff who work in the services day in, day out, literally 24 hours a day, 7 days a week. And I should point out also, just as a matter of interest, almost 900 staff have engaged with the Independent Maternity Review to feedback their stories, their concerns, and the things that work well in the service. And we expect that to be a major part of the Independent Maternity Review when it's published. And you'll probably know from media reporting that the publication of the Independent Maternity Review has been delayed until June 2026. That's to allow time for the work to be done. It's very complex, demanding work, but also time to include some additional cases in the review which relate, by and large, to neonatal cases of babies that were born outside of Nottinghamshire but received some of their neonatal care in our hospitals. So very briefly on the report, under governance, you can see one of the major pieces of feedback from the families and from Donna Ockenden is about the way that we process access or requests for information, whether it's subject access requests, freedom of information requests, or access to medical records. I won't go through the report in detail because I'm sure you've read it. What the report sets out is our improvement aspirations in that service, including significant additional resource. Most of that resource is now in place. We are still dealing with a backlog. We've had to curtail some of the additional hours and overtime we were initially using to clear the backlog because of financial constraints. But the positive news is that the service is now fully staffed under its newly restructured guise, and we hope that we'll see an improvement in response times as a consequence of that. As far as complaints are concerned, we do deal with complaints across the whole of the hospitals in a central complaints team, which is led and managed by Tracy's colleagues. We're also working really hard on the timeliness of our response to complaints, their accuracy, and levels of compassion and contrition that we show when dealing with concerns that are raised with us about any aspect of the Trust's care and support to patients. And that, of course, includes maternity services. Other aspects of governance which are highlighted in the report are around how we support birth reflections, so helping women and families reflect on what's happened to them in their maternity journey. And again, a broadly positive picture. Over 300 women have been referred into that service in recent times. We have increased our resources around reflections and listening to women and families, and our clinicians have come to understand the need to reassure women and families who are currently going through our maternity services. Obviously read the same reports of the maternity review in the media as you and I do. I'm spending a lot of time giving out reassuring information about the journey through maternity services and, if necessary, neonatal services as well. And we know from feedback from families that they have found that positive and helpful. The next part of the report, which I'll cover very briefly, is around some feedback we had from CQC in a number of inspections, actually, about whether the wards and the areas where we provide services are kept as clean and hygienic, as tidy as they should be. And you can see in the report that Tracy leads on infection control in the trust and will, of course, answer questions if you have them about cleanliness, as instigated improvements in the cleaning regime, including monthly cleaning meetings with the head of estates around infection prevention and control, and reiteration across all the clinical settings of the need for cleanliness and infection prevention and control. We can, I'm sure, come back to that in the questions. Moving on, the report covers some feedback that we've had from Donna and to a lesser extent in complaints that we receive through maternity services about kindness and civility. The Trust has a newly established set of values and behaviours, and we expect our staff to conform with those. On an occasion where that's not the case, and we receive feedback that a patient has not been dealt with in the appropriate way and in line with our values, and we always take action using the internal processes that you would expect us to use. Nevertheless, as a consequence of the feedback that we received from Donna, we stepped up an internal campaign to remind people of their obligations to treat our patients with kindness, civility and respect at all times. And some of that is laid out in the report, and that included me writing to all staff to remind them of the need not just to treat patients with respect, kindness and civility when they speak to them, but also when they write things down about them in the medical records or in email traffic. The next section of the report provides some feedback, and again, that's a broadly positive picture about feedback we received from women and families through an annual survey which is conducted by the CQC. You can see they've set out there the areas where we are improving, areas such as whether people were comfortable with the amount of time that their partner or companion was involved in their labour and birth, through to whether they saw a midwife in their postnatal journey as much as they wanted to. And you can see, apart from that care after birth question, by and large, the metrics are going in the right direction. And to back that up, we've been doing some work on communication amongst our staff, particularly in respect of supporting fathers. We have received feedback from some fathers that they feel they're not as engaged in the maternity journey as the mothers. And of course, from our point of view, we want them to feel engaged and supported. It's a very important part of the whole maternity journey. And you can see on page 4 in the report the efforts that we've made to try and support fathers and give them the right information and guidance at every stage of the maternity journey. You can see there on page 5, I've set out our new trust values. Section 5 of the report will give again a broadly positive picture about staffing. So I think we've covered before at this committee the policy we have in the trust that we staff our maternity services above the national recommendations. They're called Birth Rate Plus. It's a tool we use to judge how many midwives we should have in a maternity unit or all the maternity units in the trust. It takes into account a whole range of factors. We meet and exceed the recommendations of Birth Rate Plus. In fact, we go 30 whole-time equivalents of Birth Rate Plus. We've had 60 midwives joined us since April 2024, and our total vacancies projected at the end of this month. That includes the expansion of our neonatal unit, is down to 16. Where we have vacancies, they're always covered by temporary staff, but I am pleased to say that since January this year, we have eliminated the use of agency midwives in the service, which is a very positive milestone in a service which is working under a great deal of pressure and has a history of using temporary staff. So that's a really positive thing. And you can see that things like our turnover rates have improved, and that we've had positive feedback from our newly qualified midwives. And a really interesting piece of information is that our newly qualified Band 5 midwives, most of the ones that we've taken on in recent years, have stayed with us for at least a year. And I think that's reflective of the support that they get from particularly Sharon and her colleagues. The picture is also positive in respect of medical consultants, and Manji is here to speak to that. When you ask us your questions, we're down to a very small number of vacancies in the service. That's particularly important in covering what we call out of hours, so overnight. And we're down to a very small gap in the rota, equally very important, because out of hours in maternity services, it's crucial that we've got sufficient medical cover to work with, particularly consultant cover, to work with the midwives and the doctors in residence. All of this is part of a long-standing maternity improvement programme. And on page 6 of the report, you can see that we've moved into a new phase of that improvement programme with a defined action plan, which is governed in the trust through a group that Tracy chairs called the Perinatal Oversight Group. That improvement programme now includes our neonatal services, so it covers the whole of the perinatal journey, and we incorporate feedback from Donna and the Independent Maternity Review and from families and from the CQC into the improvement programme so that it's dynamic and based with what we're being fed back. That's all I wanted to say about the report, Chairman, other than to say in conclusion, we are still committed to resourcing our maternity services. They are at the moment exempt from any financial constraints within the trust. We are very committed from the top of the board to the point of delivery in supporting and improving maternity services. Equally committed to working with Donna Ockenden and the police in the review and investigation. We are especially committed to building and sustaining a relationship with the affected families. That, Councillor Jackson, I'll pause and hand back to you for questions.
Thank you very much, Anthony, for that update. And I do appreciate that as Chief Executive, this was something you inherited. And I appreciate from this paper that a lot of improvements have been made very recently, although it was probably coming from quite a low base, unfortunately. So, it's really, really nice to see. It was nice to see that the new prenatal cots that seem to have been opened, and now you're transferring different cases across from each hospital, which is obviously working. There's a lot of thought gone into that, and also with the restaffing, which is really good. And I think it's also proved that this should probably look at a national problem as well. It's not just Nottingham. I think Nottingham's been highlighted, but if you view the paper press, I think there are other maternity wards or areas in other trusts as well, which are suffering a similar problem. So, which is not just a Nottingham problem. Something I think, Donna Ockenden, the more she delved into it, so the more she seems to bring up, because it's gone on now for extra 2 years, hasn't it, for inquiry, which is good, because you're getting really to the bottom of the issue, and hopefully, what she brings up can be passed onto as a national programme for maternity, going forward. One question I always find me, Anthony, you get fined for the mistakes we've made, quite heavily fined. I don't know what's right or wrong, but I just wonder, where does this money come from? You're a little bit strapped for money anyway, it's very difficult. And where does this money end up? You're taking money out of an organisation that probably needs that money to improve itself. And I just wonder how that is compensated. I don't know whether it's insurance or anything else like that involved, or does it just come off the bottom line?
So it's a very good question, Chairman. Unlike the County Council, where you can keep reserves including reserves for uninsured matters. Of course, I remember that from my time working here. NHS trusts are not allowed to keep reserves. So any payment outside of our normal budget, including the recent fines, has to be found within existing resources. And that's what we've done. So the fine will be included in our end of year budget position. We're currently on track to reach and agreed with NHS England £51.6 million deficit. Included in that will be the payment as a fine. We also negotiated with the court a payment schedule so that we can spread the payment over 2 financial years from memory, but we will account for it in this financial year. For me, of course, it's not about the money. It's about the pain and suffering of those women and families, sometimes under the most tragic circumstances, acknowledging the mistakes that we made and reassuring the court, as we did, that we put mitigation in place to try and address the issues in respect of those 3 cases. But when it comes to the money, it will be accounted in this year's budget.
I mean, which I totally agree with that sentiment. It just seems to me that we're taking resources away when probably more resources are needed to improve your outcomes, basically. Anyway, I'll open it up to members. Councillor Wilmot.
Thank you very much, and thank you all for the response that you've given to us. The report's been very informative, and thank you very much for that. My question is one that I've been wanting to ask for some time, and initially I think that the staff and the team in the hospitals are doing a wonderful job with the resources you've got. But we've got to remember that the population is growing rapidly. How are we going to combat this situation? Because it's not going to improve. The service cannot improve because you haven't got the capacity to improve it for the amount of people that's coming into the country. That's one of the biggest situations. So how do we combat that? Well, surely that some of the work that is done in the hospitals can be done in surgeries. They can be done by making sorts of cattle centres like the one I'm asking for in the book at the present time. Surely that's the way forward, so that you don't have to be overstretched in the hospital, which you are at the moment. And so mistakes are bound to happen because of you being so overstretched. I just think that's absolutely, the pressure on hospitals at the moment is phenomenal. It really is phenomenal. I've taken 2 of my people down to the hospital, and I'm seeing people on beds in gangways and so forth, which isn't a nice thing to happen. But there's nothing you can do about it because you're being overstretched all the time. And as I say, more and more people are needing hospital treatment. Obviously, we have to look into the situation. How do we stop people coming into hospitals? I mean, you can't stop the maternity situation, but you can stop some of the other people coming in. But by making sure that their lifestyle is changed, so they don't have the problems that they are addressing. But let me say, obviously, while the report highlights several areas of improvement, I welcome those, such as recruitment in midwifery and action, 60 new ones. That's excellent. I don't know how many you've lost in that time as well, because but very often that happens. You tell me how many new people have come in, but you're not telling me how many, unfortunately, you've lost. Can I say, and I like the actions in response to cleanliness and civility issues. Again, with so many people in work in the hospital, it must be very difficult to clean the situation, because there's people walking about, both staff and other people coming in and out. In fact, it was incredible. I was stopping myself from walking around because there were so many other people walking about, overstretched. I don't think you'll ever be able to stop that. But as I say, how does the Trust plan to address the long-term cultural and systemic issues identified by the Independent Maternity Review, particularly regarding the exclusivity and timeliness of responses to complaints and subject access requests, which continue to be a major concern to us all. But as I say, you've got to seriously think about the way that the whole system works to get a real good response that will help everybody and stop some of the problems arising. Thank you.
Thank you, Councillor Wilmot. I'll start, and then I'm sure colleagues will add. So, thinking about your overarching question, how will we adapt to a changing population base? Expecting the NHS 10-year plan later this year, probably in May. We're already thinking about the way that we will work to the 3 shifts that the government have published, particularly the shift from acute settings into the community. We'll work with our community partners and other ICB partners to identify ways where we can provide services out of the hospital that are currently provided in the hospital. If I take one very good example, we currently provide a respiratory clinic in the community for people who are homeless, and that avoids them coming into the hospital. I'm sure there's lots of things like that we either do or will do in the future to try and prevent people coming. Equally, our urgent and emergency care strategy and our planned care strategy, which work together, try to reduce the length of stay of people in the hospital. You're right, all of our sites are very busy. We're going to have 2 more sites with the National Rehabilitation Centre and the Community Diagnostic Centre opening in the next 15 to 18 months. And it's important that we keep pace with the changing needs of the population. We work really hard with system partners to come up with ways that we can provide services either in or out of hospital that reflect the changes in our population. And we try and use technology, new ways of working, different systems and processes. Significantly though, we await the 10-year plan, which will give us much more detail, especially about what's expected of a large acute provider like NUH, working with other partners, including the local authority, in trying to prevent people coming into hospital, and if they do have to come to hospital, to get them through and out as quickly as we can. There are lots of programs of work already in place to do that. We hope that the NHS 10-year plan will give us some more definition and some more support around that. Speaking to your point about maternity and recruitment in the report, one of the bullet points on page 5 does talk about our turnover. Our turnover is the lowest for many years in maternity, so there are fewer midwives leaving the service than in recent years. I'll ask Tracy to pick up on your point about complaints and subject access requests, but before I do, it is worth mentioning that the Chief Digital and Transformation Officer, who manages access to information, has recently agreed to work with some of the families to reassure them about improvements in the service and to take their ideas about how we could improve the service. So as well as doing things internally, John, we're also trying to seek views and opinions from people affected. Tracy.
Yeah, so I think in detail in the paper, from the subject access request, we have redesigned the service so that it is more responsive. We've looked at the number of requests and matched that to activity and demand so that we can really understand how we respond to these. Some of these subject access requests are really detailed and very complex. And we also have a lot of information moving from ourselves as part of the independent review. From a complaints perspective, again, we've got a very strong focus on complaint responsiveness. Now, one of the key issues for us is how we respond to complaints and able to have that immediate response so that we're dealing with any concerns immediately, that we're working with families and complainants to make sure we're addressing their concerns. We've developed the family liaison officer role, and again, that's part of trying to make sure that we're responding immediately. So we have a whole organisation kind of complaint improvement process, but also what we want to try and do is move more complaints into early resolution so that we're able to deal with the complaints, we're able to deal with any concerns and focus on the improvement of the service.
Thank you.
And just from another maternity aspect, our birth rate has reduced. Nationally, it's reducing. So in 2010, the birth rate or the number of babies born in Nottinghamshire was around 10,000. We're now just over 7,000. So 2024 is 7,309. I know that precisely. But what we're seeing is a complexity. So the women that are coming into our care and having the babies have far more medical conditions, social complexity as well, that adds a different dimension to the care that we provide. So while the numbers have reduced, the actual amount of care that they take is increasing exponentially. With the birth rate plus and how we work out our workforce, it accounts for some complexities, but because we can apply then that professional judgment, that's why we've gone above in our numbers. And from our community, the majority of our care is provided in the community by our community midwifery services. And we're doing a review of that and looking at where they are located. But we've also introduced consultant obstetricians go out to the community and do a couple of clinics at Mary Potter, for example. And we've expanded our female genital mutilation clinics into a couple of other venues as well, and expanding that so that they're not coming to the hospital and are seen by a specialist midwife. So there's lots of things that we do to provide care in the community rather than coming into the hospital.
Okay, thank you. Thank you very much. Councillor Martin.
Yeah, thank you, Chair. Morning, Anthony. I'd just like to remind you that 10 years ago, you were the first person that brought me into this room looking for health scrutiny, and here I am still here.
I've got something right.
I didn't know where the room was. You brought me right over the building. It was like walking through a Moses. Yeah, so anyway, it's clear that there's considerable laudable efforts being made at the maternity. I'll focus on maternity. But obviously the reality is, and of course, I know you're getting flapped around by different governments promising you one thing or another, and you've just mentioned the 10-year plan. So if you focus more on that, because obviously major investment in NUH in the university hospital is what we really need to implement to have a better successful outcome for whatever comes from the Ockham report when it comes out. Yeah, one of the things I'd like to focus on is, you touched on it briefly, is not staff retention but staff training, because obviously in the initial one of the problems highlighted back when it first came to the foreground was that some of the staff weren't fully trained in the equipment that was available, and obviously staff numbers is another thing, and like John Wilmot quite rightly said, your staff retention is equally as important because of knowledge transfer as new staff recruitment and their training in the equipment that's available, because they both have adverse impacts on the outcome and the situation that we unfortunately face. And I'm hoping that there's an improved format and a more measured approach to make sure that we've got the right staff on all the time and not just some of the time, because that's really an issue, because we all know that babies can come at any time of day, and that is the issue. I know you've highlighted the fact that we've got more complexities, which makes it worse, because some of those complexities can only be dealt with by people who are trained in that particular area. So obviously that's one of the areas that I think we may need to focus on. So if you can just give us a bit of a reassurance that kind of process is being micromanaged, if you like, because that is a complicated thing. Thank you.
Yeah, thank you, David. It's nice to see you. I can't believe it's 10 years. Okay, so I'll start off with investment, and then I'll hand over to Sharon to talk in detail about the way that we plan and manage rotas and staffing and the tools that we use. I'll also ask a combination of Tracy and Sharon to pick up on training of staff. When they've done that, I'll ask Manji to add anything around training of our doctors, if that would help. On investment then, so you know that we were originally part of the new hospitals building programme, which is receive somewhere between 1.5 and 1.7 billion pounds worth of investment starting early in the next decade, somewhere around 2030, after a review of the new hospitals programme conducted by the incoming Secretary of State. We've now been told that that won't be for a number of years, probably late 2030s. And we've paused work on what we call tomorrow's rate, which was our exposition of the new hospitals programme. Now, that doesn't mean that we don't receive capital support. We do. In fact, only on Friday, I received news that we've been given £2.5 million for a new radiotherapy machine. We're currently building a new elective procedures hub at the City Hospital. In recent years, we've built wards and new theatres. We're building the NRC. We're building a community diagnostic centre. We've built our new neonatal unit. In fact, we've had one of the biggest capital programmes in the NHS for a couple of years running. What we really need is support for the fabric of the building. A lot of our buildings now are past their sell-by date, and we need to improve them. Our maintenance bill is the highest in the NHS outside of London. So what we're most concerned about is keeping the show on the road every day and keeping the patients and the staff safe, which is where we're now focusing our attention. As a consequence about the new hospitals programme, I've asked our Director of Estates and Facilities to conduct a review of all of our estates so that we can prioritise the investment that we'll get in future years, particularly into the backlog of maintenance. So, Sharon, if you'd like to move on to how we manage training, retention, rotas and planning of staff.
I can do that. So we have a 24-hour manager on call to support the service, and that's weekends, bank holidays, nights. And we have a 9:30 meeting every day, 7 days a week, and that's for escalation of any issues or for support. We have additional meetings through the day that we can also stand up. We have senior midwives that staff that, so certainly on a weekend it's myself or my deputies that do that on call, so there's very senior oversight and support. We've also invested in our band 7, so our senior midwives, so we have a minimum of 2 of those per shift on the labour suite. One of those is a flow coordinator who has that sort of helicopter view of the whole service as well. Regarding the sort of the complexity of women, we have really excellent support from critical care outreach teams who have that more specialist knowledge around medical conditions. We're also developing our maternal medicine elements from the obstetric and midwifery perspective. We have a 24-hour anaesthetic team dedicated just to obstetrics as well. So we have really excellent support, and also interventional radiography for women who have invasive placentas, so they need additional support. So that again, that specialist support is there. From a midwifery perspective, we also support our midwives to do enhanced midwifery care to support those women that have those high needs that probably traditionally we call sort of HDU, or high dependency care. So they have enhanced skills to do that, and that's supported by our critical care colleagues. As part of the preceptorship, so our new incoming midwives have dedicated training on all aspects that we need, including the equipment training. And we've also achieved over 90% of our staff, I think it's about 92 or 93% now, and some areas it's up to 100% on our obstetric skills drills. We do in-place skills as well on fetal monitoring and newborn life support, and that's a measure that we report regularly to the board as well in terms of our training. So we're very responsive to those things and looking at how we can organise our services to ensure that the women are in the right place. We've done a lot of work with the new neonatal unit opening at Queen's, and that City's now a level 2 unit, so it's a local neonatal unit with the tertiary centre at Queen's, and the pathways ensuring that women are in the right place at the right time for the care level that they need to.
Yeah.
One of the other key areas that we look at from a midwifery perspective is our workforce planning. So we work very closely with the two universities. So Derby and Nottingham University are our two training areas for our midwifery workforce. So we look at not only the skills that are required now, but the skills for the future. And I think Sharon mentioned prompt training, which is the multidisciplinary kind of simulation training, is really important, because it actually, by training people through simulation, you're able to give them a wide range of different scenarios, and then they rehearse it so that they have that skills before they're actually in that emergency situation. We've involved our Maternity and Neonatal Voices Partnership, and that's new for us. So they're very involved now in our oversight meetings, but they're also involved in some of our training to give staff that real life experience and that feedback through maternity. We have had an assurance visit from NHS England workforce to look at our training environment and making sure that we're able to deliver that education, training, supervision and support to both midwives in training, but also a very strong focus on that preceptorship, so that year at the end of their training where they're transitioning into being very autonomous midwives. So I think, again, as Sharon highlights, we've got a number of key areas. We've also looked at some of our specialist midwifery roles, some of our bereavement roles, some of our neonatal kind of specialist roles. Key focus for us as well is our neonatal transitional care service. And again, as part of our neonatal improvement programme, we've been working this year on what we call our CNST, 10 safety actions, and we've seen some significant improvement in things such as our training compliance, which we're able to assure and report to the board and to NHFT.
I'll just add a little bit more about the medical training and the medical supervision. So all of our doctors are trained under the Royal College of Obstetrics and Gynecology curriculum, which is very structured. And in fact, we had a visit from NHS England Education at the end of last year. It was a return visit. There was lots of positives of that visit in particular. And there was mention of a change in the culture, that the resident doctors felt that the culture was more open, that they felt more supported by the consultant body. As well as that, though, there was still some issues which we were aware of and working through, particularly around the way that the rotas were and the visibility of the staff that we'd got. And at that time, there was some gaps in the rota. And due to that, we have been moved into supervision level 2 out of 4. And we've submitted an action plan, which has been accepted. So not only do we have the staff in various places, we need to make sure that those staff have the correct skills to be doing what they need to do. And particularly the medical staff, they don't work just in one area of the unit. They might be covering several other areas: wards, clinics, outpatients, theatres, etc. So we need to be able to match the skills off with the team that's available and the job that's required. And you can imagine across 2 sites, that's a really complex job to do. And in fact, we were trying to kind of do those manually. We've now started to roll out an electronic way of doing that. So we've got much better sight of the staff that are available, much better sight in advance of where those gaps might be in rotas, so we can respond to those. As well as that, we have been recruiting well into our positions as well. So hopefully when the new consultant starts, we'll have about 1.5 gaps in the consultant body, but we're also really pushing through the resident doctor and the middle grade cover, which are the doctors who are actually there on site. And we're doing a lot of multidisciplinary training as well, just to make sure that that they are genuinely working in teams rather than in silos of themselves. We've also, so the medical staffing part, we've now got a particular oversight through the group that traces chairs. We've also started to do some improvement work around early pregnancy and some of the training and support and skill and staffing that we need around early pregnancy as well.
Thank you very much for that. Thank you. Councillor Reddy.
Yeah.
Oh, sorry. That's my hand.
Yeah, I mean, the reason I asked the questions about recruitment and retention and the maintenance and improvement programme is because generally, once the system starts to fail, it's the morale of the staff. And of course, under the inquiry, there must be a huge pressure on the staff, and the perception is by people coming in that it's already bad. That's the perception of the public, and that's the stigma we're trying to remove, isn't it? And hopefully the inquiry, when it comes out, will remove that for you. So the main thing is, if you've got students coming in and you've got staff staying, then it means you're paying the right money and you're getting in the right area, and that's good to see. Thank you.
Thank you, Councillor Martin. Councillor.
Thank you ever so much for coming back. It's quite a different report to when you first started coming with this. So I'm really thankful of the improvements and the way, especially Anthony, how you vocalise what's happening. I think I respect the way you've dealt with this fully. There's still more to do, and I think it's evident that there still is. But there are some really good points in the report, and not using agency midwives is just amazing from when we had conversations before. I've still got concerns about the preceptorship aspect, because I think when you've got 60 new staff, I don't know how many of those are newly qualified, but they always need a little bit more support. So although it's 60 new staff, how does that work in actual people? Because I know they have to have the support when they're actually working. I think there's some really good bits around bringing the fathers in, because I know that's something we've spoken about in the best start strategy and things, and having bringing dads in. So I think that's a really good point as well. I think my only other concern is on page 4, which is the question that scored the worst amongst the trust. That worries me as someone who has had a baby, and it's a very scary time not being able to see a midwife. I think having that as such a low score, that worries me. I just wondered if you could elaborate on what you're doing to make that better. But all in all, I think it's a much better place than you were before. I still think there's more to be done, but thank you ever so much for coming and bringing it to us again.
Thank you, Beth. So I'll just make one comment about culture, if I may, Chair. I should also have mentioned that Manjeet and I have a meeting with our healthcare older people consultant back at the trust at 11:30. So if we could leave by about 5 past, that would be helpful. You make a really important point about culture, David. This is broadly an improving picture, but ask staff who work in the service. They do feel under pressure. They do work extremely hard at keeping their morale up and instigating and maintaining a positive culture is extremely challenging for Sharon and her colleagues. So I would not want to give the impression that we fixed everything. We most certainly haven't. The point you raised about culture is extremely important. Sharon, are you the best placed colleague to pick up on Bethan's question?
Of course I will. Thank you, Bethan. So you're absolutely right. The vast majority of our new staff are newly qualified midwives, and that does bring its own challenges and opportunities as well, because they are freshest, enthusiastic, but up to date in terms of their knowledge. So it does create issues with our skill mix, and what we've done is we have introduced them gradually as well, so it's not been an influx all at once, so that we can manage and support them appropriately. We have legacy midwives, so these are midwives who are towards the end of the career that come back and want to support newly qualified midwives in terms of their clinical skills as well. We've just employed 2 midwives as preceptorship support midwives in addition to that as well, who will work alongside the Band 5 newly qualified midwives. We have a buddy system. We also have our professional midwifery advocates who meet with them on a monthly basis on, we call it a reflect and learn sessions, but they also give us information back to see if there's any issues. I met with a group of the Band 5s last week or the week before, and just to talk about how it was for them. We had some really positive feedback about their experiences, but there were a couple of concerns. I fed their positive feedback to those individual midwives, but also we're picking up those concerns as well. So they know they can come and talk to us, and they have really good support. We see that through their feedback, the whole programme for preceptorship. Regarding the question, it's a strange one because it's as much as you wanted, and it's a difference between want and need as well. So we do have a schedule. So women have just 3 or postnatal as a minimum visits from a midwife or a support worker. We always have the first visit with a midwife, and then it's based on clinical need. Women can see a midwife as much as they need to, so it's not restricted to that 3. So it's a strange kind of a terminology, and we do review that, and I'm confident that women that do need that additional care have that care. And we are looking at it through support from the MNVP colleagues about how we can make sure that women have access. So again, we're looking at our community midwifery provision. Where is it? We're not great on postnatal clinics, for example, and I think that's something that we need to explore more, so that women have an appointment, come back to a place, and using our existing facilities at a weekend, for example, we've got antenatal clinics that we could offer women an appointment to come back to there. So there's a big piece of work going on around how we do that. And women have access to the maternity advice line 24 hours a day, up to 6 weeks after the birth of the baby. So, and we do see women up to that time back in maternity services too.
Very much, thank you for that. Councillor Turner.
Just briefly, you mentioned added complexities. Can you just dig a little bit deeper and give us a...
Blimey. Oh, you can, yes.
Okay, if it's all right, I'll take that one, because when care becomes complex, it usually sits in obstetrics rather than midwifery, which is where doctors get involved. So the sorts of things that traditionally come under obstetrics are previous medical conditions. So if someone might have a respiratory condition or a diabetes or high blood pressure, etc., that's where you need certain types of care, and there's very kind of clear national guidelines of how to help women during their pregnancies. Now, pregnancy physiologically creates strain and stress onto the body. So if there is any pre-existing conditions, there is a risk that those can get worse. There's also a very close correlation between being pregnant and mental health conditions increasing as well. And there is a higher risk of mental health illness and a higher risk of suicide during and straight after pregnancy as well. So things need to be looked at much closer, need to be monitored much closer, not only for the mother but for the baby as well, because obviously it has an impact on the baby. What we are finding is, because generally those kind of additional medical conditions are rising in prevalence amongst certain communities, and that's for several reasons. What we're finding is that we're getting more and more women who are coming into the service who've already got those pre-existing conditions. A very good example of that is obesity. So obesity just creates a lot of additional issues during pregnancy as well. And smoking, for example, has a lot of issues, not only for the mother but the baby. Substance abuse, homelessness. So as well as medical conditions, there's a lot of socio-economic and demographic issues as well that we need to consider. We know that maternity care in this country, the outcomes are still poorer for certain members of our community, particularly for communities who are either asylum seekers into the community, but also for Black and ethnic groups, and for people who have learning disabilities as well. And we are finding that there are more people within those communities that we serve. That's just a few examples of how care is becoming more complex.
Thank you. Councillor Henshaw, I'll make this last one. You have to leave it that.
I'll try and keep it brief then, Chair. Thanks for coming in, Anthony, today. It's interesting to see the ongoing information that you're giving us. I just want to ask a few specific points. In relation to complaints that you manage, and it says that you have dedicated complaints team, how do you get the complaints directly from the people that use your services? And then are people who come into the hospital aware of how they can complain if they need to? I mean, do we have a PALS service still, or a patient's forum or something? Just put a little bit more, give us a little bit more information on that. I mean, somebody like me, I've been involved with CQC involvement and visits for over 20 odd years in my professional capacity. And I always understand that when the CQC are coming in to do an inspection, a lot of people end up being, they stand back and they've got a lot of trepidation because they don't know where it's going to come from. But as highlighted in your report, it's been extremely useful for the CHC to come in and make recommendations that you, as an organisation, will have to adhere to. Even when you look in the report and it said they highlighted where curtains weren't being changed, and you immediately sorted that problem out. So in that respect, the CQC and the independent review as well have given you something to work on to improve things. So when you look at the point on cleanliness, can you just give me a little bit more information, or one of your team, in relation to how you're going to meet those recommendations or those points that were highlighted by the CQC to make sure that the hospital is clean? Infection control is vitally important, so a little bit more of information on that would help. And also, it's been touched on about staffing, the lack of civility and kindness. I'm glad that you've highlighted in the report that is an area where you're going to concentrate, because as anybody knows, one of the basic things you expect when you go into hospital or meet with any medical professional is that you've got empathy and you've got care and compassion and kindness, and those are the important things. And if you've got those, in many respects, it aids recovery. So can you give a little bit more information on how you are going to make sure that your staff are treating patients and people who visit the hospital with care and compassion? Thank you.
Thank you, Paul. Okay, thank you, Paul. Nice to see you. So we'll work through those. Tracy will pick up cleanliness and infection control. I'll ask Sharon to talk to the issues around civility, kindness and compassion. So Tracy first, please.
So yes, we do have a PAL service. So we have quite a comprehensive patient experience kind of remit, and work very closely with our patient kind of council. So that's been part of our quality strategy over the last year, is around our patient experience. So it's a whole range of activities that we undertake. We have patients that sit on a number of our committees, including our IPC committee. And part of that role is to make sure that we are keeping kind of connected with patients and their families, and also their experience. So there's a lot of different activities that we undertake. We take the FFT, so friends and family test. We've got volunteers across the organisation, and again, part of those roles are to gather information and feed things back. So what we want to try and do is have a very open listening culture across the organisation and make sure we're hearing many different voices around the experience, not just through a complaints process, but through our everyday activities. And when I met with Trish Cargill, who's chair of our patient engagement group, she undertakes, we have place visits with 15 steps, we have a whole range of different visits, but she also attends a number of our different kind of meeting structures to give feedback. And I know she feeds back directly to Anthony, she feeds back to myself around those different activities. So when we were experiencing in winter high boarding levels across wards, they were doing some work with us around what it felt like to be a patient in those kind of spaces, what things we needed to think about. So there's a lot of work, and we constantly look at different ways to look at patient experience and improve that in our year going forward. Again, that's one of our key areas of improvement, and we've put targets on that to really focus on how to experience our services. We have also an ACE accreditation process, which is our Accrediting Care Excellence, which is a supplementary focus around all the things that happen on a ward. We have our Tendable audit programme, again, which goes through the environment, it looks at cleanliness, it looks at our different elements, which kind of leads me on to the cleanliness. So we monitor the cleanliness on the wards. So we do it through both the self-assessment, so the ward leaders, but they also have peer visits, so they don't check their own homework. So we've got different wards that will go on and they will look at bed rails, they'll look at the cleanliness of the ward, they'll make sure that we've got cleaning schedules for each of the areas and that we're adhering to that. We've got the healthcare standards, so that's the thing that we measure against. So the curtain issue has been, so the healthcare standards would suggest that every ward in environment you should change at least 6 monthly, but if they are contaminated, so if you've had an infection, you change them more readily. We have disposable curtains in some areas, and again, that's quite easy to mark and say when they've been changed. The issue is where you've got fabric curtains, they're changed according to a schedule, but actually it's not logged effectively. So when the CQC came in, they said you couldn't identify when the curtains were last changed. So we logged those now, and we've gone through a programme making sure that each of the wards and departments take oversight for that. So IPC sits on a monthly basis, and we look at a range of information around the cleanliness, around infection rates and things like antibiotic use to really bring together a real strong focus. There is what we call a board assurance framework for infection prevention and control that has a whole host of issues around compliance, our education, our training, and that's what we look at a monthly basis to make sure that we're meeting our training requirements, that staff are educated and understand IPC. And then we have our IPC team that work with the specialist areas and make sure when we've got outbreaks that we're going through a range of things to make sure we're keeping the patient safe, but also the environment is protected.
And from a kindness and civility perspective, we have a culture engagement work stream that is a thread across everything that we do. So some examples of things we've done around feedback and giving staff the tools to be able to feedback in real time to stop low-level issues becoming these big things. We hold our values really clearly, and we hold people to account if they're not practicing the values that we have within the trust. And it's really important that we have a clear vision and roles and responsibilities and those expectations from myself and through all the levels of staff, and that comes down to that role modelling. So we do give that really positive feedback to individuals when they've done a great job. And when it isn't going so well, we also have those conversations, and it comes from a place of support, because people don't come to work to be unkind and mean. So what is it that's going on with them? So we have a really robust wellbeing offer for our staff, and we employ psychologists to work within maternity and neonates as well, so that staff can have that additional support, so that they can sort of reflect and recognise themselves when they need that additional support to address how they're feeling in that, a really complex view of maternity.
Thank you. Thank you very much. Thank you. And thank you for coming in this morning, answering questions. I mean, we're on a journey now, aren't we, going forward? It is a very much an improving journey. I'm sure on Don Octon's report comes out, there'll be a few more things highlighted, because I think it's important that for couples having childbirth and children is one of the most important emotional things they ever go through as a couple, and they need confidence in the hospital and the place where they're having the baby, and etc. etc. Please go away, because I think we proved today that there is an improvement there, and which we're grateful to see, and we do thank you for coming and answering questions, and let's hope going forward we can see more improvement. So thank you very much for coming in this morning.
Thank you very much.
Last time I have a meeting in here, Anthony.
Yeah, it will, actually.
Yeah.
Good luck on Thursday.
We'll go through health and safety first.
Thanks a lot.
Thank you. Right, there's two recommendations, members. That feedback of members on the progress made regarding improvements in response to feedback from the Independent Maternity Review and the Care Quality Committee be noted, and that a further update regarding revised picture of the future of tomorrow's NUH be considered for inclusion in the work programme for 225-26 administration. Can be noted? Thank you, members. I thought that's very good. I don't know what you did. Yeah, therefore.
Still fun.
Okay. Okay, item 4, outcomes of health scrutiny. Is that right, Miss Open? Have I missed one?
We're bringing up the side.
Okay,
Because our officers.
right, okay. So we can have outcomes of Health Scrutiny Committee review of school readiness. This is a report seeking endorsements of findings and recommendations on the review of school readiness, which was carried out by members of the Children and Family Select Committee. And I'd like to bring Councillor Eddie in, who chaired that review, to say a few words.
Thank you, Mr. Chairman. I'm really proud to introduce the report and the findings and recommendations that are summarised on page 364, which was the report on school readiness, which was set up in response to a number of questions raised in this committee about children entering school after the pandemic and if they were ready. And it's something that I wanted to highlight because my daughter started school in September, and I think there was a number of children that were affected quite heavily by the COVID pandemic. As described in detail in the report, school readiness is a measure of how well prepared a child is cognitively and socially, and is also an indicator of how ready a child is for learning in a school environment. The objectives of the review were to identify the issues affecting school readiness in Nottinghamshire and examine the services which offer support to families to get their children school ready. There was a number of things that were scrutinised during the review, including Nottinghamshire's Healthy Families Programme, the childcare sufficiency in early years education, and we also had a case study from Rampton Primary School, which is the NTU's Getting School Ready. The review looked at a number of factors that contribute to some children being less ready for school, such as early years development, and members also considered evidence of what works to ensure children are meeting their highest potential. The findings of the review showed the importance of accessing early childhood provision in supporting families to prepare children to be ready for school. The review sets out 6 recommendations which are set out in the report, which aim to help promote school readiness in Nottinghamshire. I want to thank members who participated in the review, especially Irene and Helena, and thank you for being here today. And also NHFT and NTU partners who came along to share evidence in the review. I am really, really confident that some of these recommendations will have a huge potential to do so much good for the children of Nottinghamshire. And I'm really glad that the ICP are taking on that children and young people are one of their priorities, specifically moving forward in the new review. So I'm really, really grateful to everyone who's been working this. And if we can make a difference for some little people, I think we should. So I'll open it up to questions, and if anyone has any comments on the report, and then it will go to Cabinet, I presume, in the new administration.
Thank you. Yeah, Callum.
Thank you very much, Mr. Chairman. Not too many questions, to be honest. As the report indicates, I actually sat at this review. But I just wanted to highlight the fact that a lot of work went into the review. I found it very productive, and I definitely takeaways that the council could use. And I was very highly encouraged. I believe it was the Prime Minister who set out school readiness as one of his priorities, and I certainly hope that even if it's not just in Nottinghamshire but nationwide, that this issue's really got into grips with. Thank you, Chair.
Thank you, Callum. Are there any further questions? I think well, Councillor Martin.
Yeah, thanks. I'd like to thank the working group who carried out this thing. I know it's a difficult juncture because we're having an election, and it's difficult to plan for the future. But when you look at the disparity as highlighted on page 18 and 19 between Rushcliffe versus Mansfield and Ashfield, you know, it's quite, and being an Ashfield county councillor, it's quite shocking. But again, you know, and I do think, I know there's been an argument to and fro between either side over Shore Star centres that have been reduced in number, and I do think that any incoming administration ought to look at funding for that, because they create a natural hub for parents, especially in the more rural isolated communities, to find somewhere to access information, and not just access information, but access shared living experiences with other mothers and young parents, because communication is key. That's what this paper is all about, really. And I do think it's worth spending a bit on short start centres where they are, because they are like outreach centres, and very much like we've done with the library programme, where we've gone into other buildings and kept the service. I think that's probably a model that could be rolled out as short start centres, although I'm not saying take the kids into libraries. All right, so I think going forward, whoever takes the new administration needs to look at the recommendations, and it is a key thing, because obviously those first early years are crucial from 1 to 2 to just basically absolutely crucial. Thank you.
Thank you, Councillor Martin. Lou, you want to add to that, Irene? Or
Absolutely. I mean, I think the idea of having community assets that people know and trust and can go and ask for information is fantastic, and that's something we've continued to do. There might have been some changes, but the family hubs now, so the Short Start, the children's centres now, family hubs still provide those services from maternity to age 4. In fact, during COVID, started to do a lot more work during maternity. But I think it's broader than having those physical buildings. So families are telling us they want more information digitally. They want more on Facebook and things like that. And it is Facebook for a lot of our parents. We all thought it was Instagram, but it's not. So it's that sort of thing we need to get out all the time and get those underrepresented groups.
Thank you very much. Councillor Henry.
I was just going to ask about how is it promoted? Because some of my families don't always know it's there because it's new family home. Is it just for those families that we think are having difficulties, or is for everybody who may have difficulties and might need something like that? Because I don't think they don't know where it is.
But we've got we are doing a lot more campaigns and information at the moment to launch kind of the big family hubs. There's a launch this afternoon in Norrington. So we're trying to do as much as we can. We are just getting lots of things printed at the moment. So there's a printing section that got dropped off this morning. So there's all of that we're going to do. The other thing, I'm going to ask Helena just to mention this resource that we've produced. Sorry.
No, go on. We've worked to develop a Best Start for Life local offer, which is aimed at telling all our parents and carers exactly what services and support are out there for them across the whole system and how to access them. So obviously, family help Facebook, as is signposted to the digital at the moment, and we're looking to strengthen and evolve it in line with the recommendations from the report today. And we're getting this out really widely, so we've got posters everywhere, hopefully, that children and families go. Every new parent who goes to register a birth receives a QR code, is distributed and help the family teams and also through access that way.
So I think that as part of that, that's part of our universal offer. So information for everybody. When you actually going into the family building, there's a mix of targeted and universal work. So we've got under ones groups and parent groups, which are universal, maternity services, healthy families and so on, as well as that very targeted.
Thank you.
Hiya. Just looking at what you've said here about supporting communities and families, and the council has pledged to strengthen relationships with the voluntary community sector. Can you say a little bit more about what that means and what that looks like?
Yeah, absolutely. So there's a couple of things to say. Early years providers at the moment, we've got a lot of preschools that are all voluntary sectors. We work really closely with them. But as part of the family hub developments, which have stemmed from children's centres and the work with public health, we have now local partnerships, and the voluntary sector is key to that. So that each family hub network will have a locality, and it's for them to really bring together those partners. So sometimes it's a national organisation like Home Start that has local delivery. Other times it's a small organisation that provides counselling for parents. So that there's a real range of things. Baby banks is something else in the voluntary sector. So we're doing what we can, but we always welcome other smaller charities to get in touch with us as well.
In terms of that parent and community voice, we are working on refreshing our Best Start strategy at the moment. Our original iteration comes to an end in 2025, and as part of that, we are very much looking at having parent representation on our new Best Start strategic partnership, and we hope that will rise up from the parent carer work that Irene mentioned happening around our family hub networks, and I think just more generally the recognition of the importance of that very much local place-based community support will really come through.
So I just want to say, I think this is the start of the conversations. It's not the end of it. I think that's the thing. This is meant to be a sort of start in the point, and then we move forward and we do as much as we can. And I think it's about, the recommendations are about us doing just simple things, isn't it? Like, you know, when you get your school email address, when you do your school picks before going, have you thought about school readiness, and putting it all together in a way that we haven't at the moment. So I think it will really help children in the future. So I really, really hope that people can get behind this.
Okay, thank you very much. Councillor Wilmot, sorry.
Yeah, I think this report today, it's so serious that you know, our children's lives you know, are the number one priority, because they've got to take over the running of the country you know, in time and so forth. So it's essential that every child gets a chance of learning, or whatever the situation is, and we can't do it all on our own. There are libraries that got the opportunity to learning sessions in there and so forth. The churches, each of the churches now have a children's worker that actually educating them. You know, we have to work more closely with those to make sure that they're aware of the issues, so they can report a child that is a little bit further back than some. So make sure everybody, all the children, get tremendous opportunities. Communication again is right at the top of the hit parade as far as I'm concerned. We've got to make sure that every family knows where the help is available. You know, and we've got to really make sure that that's an absolute certainty. Children's skills. I mean, there needs to be more one-to-one activities taking place. My daughter actually works with children on speech therapy, and she tells me that the lack of resources in that area is phenomenal. And so we have to look at those sort of situations, make sure that every child, as I say, gets an opportunity to learn, to become, do something in life. We just announced that 2.8 million people that are inactive at the present time. You know, we have to try and cut that out, and the way to try and do that is to get the people into education, more education, further at an earlier age. That's a priority. As you've already said, community groups. There are a number out there, you know, waiting with this to give assistance, but we don't know about them. You know, we have to really get involved in that. And as I say, the services and area coordinators all have to be realise that there is a lot of help out there for us personally to make sure that every child gets an opportunity to do their best in life. Thank you.
Thank you, Councillor. And a really quick question. A good summing up though of everything. If you want to comment on it or no?
Well, no. I mean, I think that the most important thing in terms of the research as well is equipping and giving the confidence to parents to start it early. So the best educators are actually families. So if we get that bit right, then we can move on to the next.
Lovely. Thank you very much. I'd like to thank Councillor Eddy and the subgroup for doing this work. Very important work. Coming out with the conclusion. I think it was covered in Children's and Families Committee yesterday as well. Reported to us, was it? Yes, you mentioned. Okay, yeah. And I'd like to recommend the recommendations are at point 63 on page 14 of the papers, 1 to 6. That come out of the committee, and I think as Councillor already said, there's further work probably to be done in the future going forward. So, can I have a second for that, please?
Yes, Chair.
And all those in favour? Thank you very much. I think that is unanimous. And thank you very much again, Councillor, for all your work. Ariel and Eddie coming in as well today. Thank you very much. Right, okay, we'll probably just have a short break. We're still waiting for Diana Hull to come in. So yes, she's on the way. So if you want a 5-minute break, fine. Okay. Thank you. And welcome, Diane.
Thank you.
Dan. And Dr. Coming in this morning. The next item is the Theemis review and improvements updates. The consideration on the briefing and implementation of the recommendations of the Theemis review. This update was requested on the April 24th meeting. So I'd like to welcome Jan and Diane. Doctor, over here.
Dr. Gedeon, it's G-E-D-E-O-N.
Yes. Sorry?
It's Dr. Gedeon, G-E-D-E-O-N.
Right, thank you very much indeed. Would you like to just introduce?
Shall I start by giving a general introduction? So thank you very much. I'm Jan Sensier, I'm the Executive Director for Partnerships and Strategy. You'll recall that initially we were coming today to give you an update on Rampton, which we'll come to in a little bit, but I know that you asked additionally, Chair, if we could come and talk about the fact that since we last met, with the publication of the Theemis review. The Theemis review is an independent review that the NHS England will commission when there is a homicide involving a mental health patient. This review is incredibly thorough. It took place over several months, and you will see we did give you the report alongside as an annex, so you've got that full report. You'll see from there it's extremely detailed, extremely thorough. Clinicians, families, the review team interviewed many people and reviewed much documentation in order to produce that report. And we knew that would be published at some point in the new year. It was eventually published towards the end of January. And we also knew that it would, of course, attract significant attention, which it has done. As a result of the review, there are a number of recommendations. Some of them are for other bodies, but there are a lot for the Trust. And what we've also sent you as one of the annexes is the action plan that we've put together with our colleagues in the Integrated Care Board. It's a joint action plan, and I know Diane, who worked very hard on that action plan, can answer further questions about that. Additionally, because the review highlighted some issues that have applicability across all mental health trusts, a letter was sent out by NHS England to all mental health trusts asking us to look at 5 particular areas around the personalised assessment of risk across community and inpatient teams, because risk assessment was one of the key themes that came out of the Theemis review. Around joint discharge planning, one of the issues was concerns that we discharged Valdo Calacane due to non-engagement, and there wasn't that multidisciplinary approach and that working with families in terms of that discharge. So NHS England have asked all trusts to look at their process around that joint discharge planning. And thirdly, around that multi-agency working, because working with primary care, particularly when you're talking about community mental health services, is absolutely key. And so that's been asked for. Working closely with families is the 4th area. Again, one of the issues that came out of the Theemis review is that at times the family contact was very good, but at times it wasn't quite as strong, and it highlighted the importance of working with families. And finally, eliminating out-of-area placements in line with the 3-year plans of the Integrated Care Boards, because unfortunately it has been the case over a number of years that mental health trusts, including our own, have placed people in out-of-area placements when there's not been sufficient beds within their own area. And one of the things that came out of the Theemis review was that that led to some discontinuity of care for Valdo Calacane, and it is better, generally speaking, for patients to be cared for in their own area. So those are the 5 areas that NHS England have asked all trusts to look at, and we've given you an update on what we've done about that. I've been on leave, so I haven't actually got the very latest figures, but certainly just before I went on leave, just to reassure you, for instance, on the out-of-area placements, we had no inappropriate out-of-area placements. I don't know, Di, if that's still the case, but I think it is. We started the year 24-25 with over 50 out-of-area placements. So we have worked really hard on that. Just to point one of the things, there's a lot of other detail in the report. You also asked about the judge-led inquiry. We know that the Prime Minister has announced that there will be a judge-led inquiry, a statutory inquiry, and we have seen that report obviously in the media. We know that that is coming. At this point in time, we have no further information about that. We're still awaiting the terms of reference for that inquiry, exactly what the scope will be. Picking up from the media, we think the scope may well involve other agencies as well as our own organisation, but we don't have any confirmation of that at this stage. What we are doing, and I know it was really good that the committee were asking particularly about the support that's in place for the staff that have been affected by all of this, and we're really grateful that you asked that question. We have been doing a lot of focus on that. We are aware that it's very, very difficult times for our clinicians, and Diane will say more about that because I know Diane has spent a lot of time working with those clinicians, but we have put in some very, as well as our overall trust offer, which is a good offer on wellbeing, we've put in some very bespoke support for the clinicians that have been involved in that. What we are doing in terms of preparation for the inquiry, whatever that may be, is we are putting together a team because we know that an inquiry will require a huge amount of information and data, and that takes a lot of resource to put all of that information together. What we don't want that to do is to detract from the work that we do in the trust generally. So we're putting a separate team in place so that we're able to manage that workload. Chair, I think the other question that was asked about working with partner organisations, Diane again can say more about this, but we are working really well with the police. Diane has regular meetings. I think you've got one later this week, haven't you, with the Assistant Chief Constable. But also the ICB, the Integrated Care Board, has a system-wide, that includes the local authorities as well. The Integrated Care System has a mental health board, which is chaired by Sir David Pearson, who many of you will know as he used to work in the county. And that involves as well the police, as well as local authorities, as well as the voluntary sector, Health Watch and others. And they have been incredibly supportive, and it's a really good vehicle for that partnership working. But we do have some very direct partnership working with the police as well. And they have just implemented the Right Care, Right Person initiative in Nottingham and Nottinghamshire, which we're very supportive of, and they've done it in a very collaborative way. So we do have some very strong relationships with the police. Just to give you a quick update on our improvement plan refresh, which we spoke about with you last time, where we're nearing the end of the process of refreshing our improvement plan. We've got further meetings this week and next week, and our board hopefully will sign off that refresh next week. But overall, we're looking at having a smaller number of priorities because we recognise that the plan had grown. We'd got 44 projects on the plan, which is too many to tackle all at once. So we're looking at streamlining the plan, having a few priority projects that are trust-wide, that we can really coalesce all of our resources in terms of making those happen. And we'll have a few principles in terms of how we work, one of which is patients and carers in every area of the work that we do. And so that, as I say, we go to our so we work very closely with NHS England, who have the recovery support team who are supporting us on this. So just to let you know, next steps, we continue to make those preparations for the judge-led inquiry. We continue to work on the implementation of the recommendations from the Theemis review, and we are hopefully nearing the end of refreshing our plan to give us a much more streamlined and focused plan, taking us into the new financial year. Thank you.
Diane, did you want to answer that?
Happy to take any questions, or I can add a little bit about the support to the team.
Just okay, yeah.
Yeah, of course. So as you remember, it was the early intervention in psychosis team who provided direct care to Valdo Calacane. So we have done a range of supportive interventions, both collectively and individually, because those people who were working directly with Valdo have needed far much more support. But in addition to that, we're really mindful that this has impacted so many people, and there will be people in our inpatient services or people who have had contact who have then moved to other parts of our organisation. So as an organisation, the individual support, the wellbeing support, but one of the real important things is around the learning. So we've had a series of learning forums. The week after the Theemis report was published, we held 4, myself and somebody from the patient safety team. We've now got a series of another 8 throughout April and May. So this will be continuous learning, and people are finding that supportive as well. So that's been, in addition to that, we've had Ifti, our chief exec, held a open forum, and we had a leadership event as well. This is something that we are going to continue to talk about, and we will continue to support people, especially as the public inquiry commences. Relationship to working with us. Actually, it's stronger and better now than it has ever been. I meet with the Assistant Chief Constable monthly, and these are really, really good meetings. But more importantly, it's our care group and our care units who are meeting with police, and they are sharing information around people, around concerns and around approaches. We, as you know, also have our street triage team who work directly with the police, and the Assistant Chief Constable gives excellent feedback about them. Obviously, we're still thinking, how can we improve that further? I attend some of their gold call meetings, and they are attending some of our patient safety meetings. So there's a real sharing of information. We're also at the point where we're going to sign a memorandum of understanding around how we do patient safety incidents, and the when and how we have contact with families, because as you remember, that was another concern around the Valdo Calacane case and the support to families. So I think that is much stronger and much better relationship, coupled with a really strong relationship with the system, because the plan, which is published on our website everywhere, has been done in collaboration with Rosa as well, the ICB. And that's important, isn't it? Because it's only if we do things together that we're going to make really important.
Okay, yeah, thank you for that. Yeah. Like our earlier agenda item with maternity, this is very high profile in the press, and we're not into at the moment to be reading all about it, and that's why we're very thankful that you've come in to explain to us how the process for the PCS report and how improvements are being found going forward. I think now that it's a judge-led inquiry, I think there's a lot more in-depth review into this and a lot more lessons to be learned, sort of thing, And I'm pleased that you're working more with the police, because they came under some criticism as well, didn't they, early on with this? And then there's also which came to light, so access to medical records, which was of the deceased, was that right? That
was actually, we have been able to go through our records very thoroughly. There were no members of the trust staff that accessed the records inappropriately. But
that was again, I was in the press. It was a lot later. Anyway, I'll open it up with questions. There are members got questions. Councillor Wilmot.
Thank you very much, Chair. Yes, mental health is a real problem, and it's escalating at this present time. You walk the streets like I do, talking to people, you notice how many people are unfortunately having mental health problems. There's many reasons for it, and far too many to go through, but and for those people, unfortunately, there's very little help. So how do we actually manage to talk to these people or get to know these people? So it can be done through partnerships, and I do welcome the partnership you've got with the GPs, the fire service, the Nottinghamshire Police Force, and the chief nurse, because they are the people who can get the message out there. And it's essential that when a police get to a person who is unfortunately doing the wrong things, that person might have serious mental health problems. And so straight away, that's one of the first things that they should be doing, is reporting that issue, so you can get onto the nitty-gritty of the work. And it's the same with charities and other community groups. The leaders of these charities should know, or they need to know the information that's required, so they get it into their brain, that they know what to look for in the problems that some people are getting. Make sure that we identify those people, if that's possible. While the report on page 2, paragraph 4.1 emphasises that complaints are now being handled through a dedicated team with weekly meetings, the initiative appears to be under significant pressure from unprecedented demand. Again, it's because of how many extra people unfortunately getting mental health problems at this time. Given the continued challenges with the delays in responses, what specific measures are being implemented to ensure that the increased volume of complaints does not lead to further delays in addressing critical issues or deteriorate the quality of service provided to patients? Can I say that it is essential that the people that have got mental health issues are referred to you. So you do need to get a paper out there to the leaders of all the organisations that have regular meetings with personnel in the community. And this face-to-face training package on clinical risk and inclusion has been developed and has been rolled out across the mental health services at speed. That's a good idea, but you've got to make sure that you get to the right people. That issue. Families and carers. Now, I work with loads of carers that unfortunately, with the workload that they've got, with the patient they've got, they're getting problems. And so we've got to identify the Carers Association, how they identify these people so they can get help. And it's absolutely essential that this help is got out there. And I do see that you're doing a lot of good work. I mean,
I'll have a question, Councillor.
Yeah, well, that is the question then, about increased volume of complaints does not lead to further delays in addressing critical issues or deteriorate the quality of service provided to patients. Thank you.
Thank you. I mean, just to start off by saying that I think you're quite right about the need for people to be aware of services, and I don't know whether the committee is aware of what I think is a really good initiative that has been produced in Nottinghamshire. It's a website called Not Alone, and I don't know how many people are aware of that, but Not Alone is a really, really good website, and it has on it access to, it signposts people to all the different services, all the things that you mentioned, Councillor, around the voluntary sector, around the different services that are out there. And there's a section for professionals and there's a section for members of the public. And so I would say that I think that's been a really good, it's been the ICB that have developed that, and in conjunction with the local authorities and the local health system. And it is something I'd absolutely commend and hope that all of our organisations can promote that to the public, because I think it is a really helpful in terms of signposting people to the right services in the way that you described. Specifically on complaints, I'm going to bring Diane in. It is something that we take very, very seriously, and we've done a lot of work on over the past year. So can I bring you in, Diane?
Absolutely. And complaints provide this real opportunity for honest feedback, don't they? And we need to respond in a timely way, in an honest way, and in a way that we can work together to find solutions. We have appointed an associate director for participation and experience who will be managing the complaints process, and we're already reaching out to other organisations, both NHS and voluntary organisations, to look at how they manage complaints and how they respond to them, because we really want to do it very, very differently. We have put in some immediate actions so that we respond much more quicker. Jan and I have been signing off complaints because we were concerned about the quality of the letter of response, and we've also, in some of our care units, have been putting in a talk to us first mechanism, so that people don't have to write formal complaints, but there's the opportunity to talk in real time about what's happening, and that has been really successful as well. In addition to that, we have matron surgeries. As part of our strategy going forward, with our new approach to participation and engagement, we will have participation leads aligned to each of our services, where those are people with lived experience of either using services or being a carer, who will also provide opportunities to get feedback and ensure that that's responded to really quickly. A big bit of our focus has been around the quality of those responses.
Which has improved.
It really has. And making sure that those responses are not only compassionate, but actually talk about our actions. Because I know that if I was going to complain, sorry would be one thing, particularly if it's genuine, but to know that my experiences might change the approach for other people would be far more important for me. So that is what we're doing at the moment.
Councillor Eddy.
Thank you very much, and thank you for being so open and providing so much information. I was reading it last night, and it was a lot. There's a lot, and a lot of information, and I think it's really good to be really open, honest, and transparent about what you're doing to improve, and I think that's brilliant. Just a couple of questions about the action plan, if I can. So you've got completion dates on them. Are we working towards those dates, or is there going to be a delay in anything? And if there is a delay, how are we going to make it so we'll get there quicker, if you know what I mean? Because I think it's such a good action plan, reading it. It's just about putting it into action, really.
Thank you. A number of these actions are already complete. So if you look at the first recommendation, it was around, there's 3 reports. So we had our internal report, then we had section 48, and then we've had this one. So our internal report recommendations are ready for sign off as complete. So we actually met last Friday to go through all of these. We're on track. And if there's where there's any kind of slippage, we are going to be really honest and open about that. We're going to be honest about the why and then what we're going to do or need to do to get back on track. But actually, we're making some really good progress. And the other thing is a lot of these are part of our integrated improvement plan. So there's a bit of we've already started the work, 9 months ago. So we are making traction with it.
And just to add on the governance side, when we take our refreshed improvement plan to our board next week, we are proposing that one of the key priority projects we have is the board that Di chairs, which looks at all of the recommendations and the milestones and the outcome dates, the completion dates, and takes that through the programme so that we've got that oversight and keeping us on track all the time.
Thank you.
Councillor Martin.
Thank you, Chair. Yeah, I'm glad that you highlighted it right at the beginning of your report that your reliance on out of area services is reducing, because obviously that's got a massive financial implication on the trust. And I did say after you came last time that I do think we should have the trust come to adult health and social care and explain the vast array of services that you actually operate, because nobody realises actually how complicated your setup is and how many people you have. And in that light, you're always going to get the odd case that runs away, and unfortunately that's what's happened in this case. And I think so long as you've got a cohesive strategy to tie up all the partners that are working with the patients, that's the main element that would be the most important thing to me. You've been let down by other services as well, including Nottinghamshire Police in that, who were absolutely in an abject failure to chase up that patient. And, I think that was a crucial element of it. Talking to the family is another one, but then also, because often when people suffer from mental health to that extreme, they get alienated by the family, and that's a good sign of a good way of communication, finding out where that's at. And I think tying up all these things, and I've read your action plan. I read the whole thing on the way to Ipswich Saturday morning. So yeah, I'm giving it away. I'm not suffering mental health from that. Back to the serious side. The cohesive patient strategy is the main thing. And of course, the non-reliance upon out-of-area beds is crucial to your finances as a trust, which helps you provide more services and not restrict re-employ new staff within your own organisation because of the constraint on your finances. You know what I mean? And I think that's a good way to work forward. So I do think we should have you adult health and social care in the new term. I think that the recommendation I'll put to the Martin Elliott who deals with it, because I don't think people understand the vast array of services that you provide. Thank you, Chair.
Thank you. Let me just Diane.
Councillor Martin, may I tell you something? I should have said it right at the beginning, but something that we have done, which actually not only are we really pleased with, but we think it's going to make a considerable difference. And it's something that other organisations are asking us for information about. So, Valdo Calacane, had we had an assertive and intensive treatment pathway, he would have been cared for under that pathway, which was the old kind of assertive outreach team. As it was, he was being cared for by the early intervention and psychosis team. Our learning from this is around the need to think about that pathway. And we've done a big piece of work around identifying anybody who would meet the criteria for an assertive outreach team. We have a live dashboard, so I can tell you today that there's 305 people who would meet that criteria. I can tell you that 281 are in the community and 24 in hospital. I can also tell you the divide between female and male, 24% female, the rest are male. Also, I can tell you the ethnicity, which is very interesting actually, because 40% are Black or of dual heritage. So that enables you to think about your interventions, think about your family support, and think about some of the factors that might lead to people disengaging. So it allows you to be really specific and really purposeful. And I can also tell you that 100% of those people have a risk assessment, 100% have a care plan, and I can tell you when their family has been contacted. Hand on heart, if I'd sat here 15 months ago, I could tell you none of that. We can now, and I think that greater understanding, that level of detail and that opportunity to do things really in an individualised way, thinking about often the most marginalised people within our communities, is something that actually it's a positive thing which has come from something so absolutely awful, and I wanted to share that with you.
Thank you.
Yeah. Thanks for that. I don't think it's any consolation to the people who have lost out as a result of that systemic failure, but it's a consolation to me as a parent with a student at Nottingham University on a daily basis.
Thank you, Councillor Martin. Councillor Anderson.
Thank you, Chairman. So on page 61 of the report, Area for Improvement 7 across organisational working, it mentions the all the different system partners not fully being involved in decision making or not being aware of them. I mean, I couldn't even begin to count the number of reports, papers in different committees that I've read about the lack of communication across all members of an organisation. And then, you know, horrible things happen. Also in your development plan, item 6, clinical information sharing. It says we found there were limitations on the sharing of clinical information across the setting, which impacted on the availability of those who were caring for BC to understand his needs. So just wonder within this plan, will all the different people that need to be involved in implementing this plan actually be aware of it, be involved in it, and know how to go forward? So things like this, you know, they may happen again, but reduce it to stop it from happening again.
Well, we need to do everything we can, don't we, to prevent them happening again, and this is a really critical area. So there are several kind of strands to this, but I mentioned earlier the system mental health board, which has all of those different agencies around the table, and they are very, very keen. They've seen this action plan, and they're very keen to be involved and to help and to support the delivery of this. So I think that gives us, you know, again, we didn't have that 15, 18 months ago, and I think that's really, really helpful. We are, as a system, and that includes again the local authorities alongside health partners, we are rolling out something called the Not Shared Care Record, which will mean that we have more digital access to the information. But it's also something that I know that Diane, you've been working on with Rosa about how we get that greater information sharing across partners. And lastly, I'll just say that, you know, the work with GPs is crucial. And I wouldn't say we're there yet, but that's something that we're really working on, and we're really prioritising, working with GPs across the system, because it is often that bit between primary and secondary care where maybe gaps can arise, and we really need to make sure that we're working much more closely with them. Sorry, Di, I don't know if you want to.
No, I think. Do you perceive that these completion dates for that work will go ahead?
Yeah, we're confident at the moment, aren't we? I don't know if you looked at that in your review. This one, it's but I think at the moment everything is on track for us to meet those target dates. There is a lot of work that's already. So if I take Not Shared Care Record, 4 out of the 6 partners in that have already gone live with Not Shared Care. So those things are already on track to meet those completion dates. Thank you.
Thank you very much. There's any more questions? No? Thank you. Thank you, Diane, Jan, and Dr. for coming in this morning. I mean, again, you're on a journey, aren't you? It's a learning journey. I mean, so many recommendations in this species report to go through terms of it. Difficult. I'm so pleased that you are now working with other partners, sharing information, getting, you know, together and seeing a bigger picture. But I think it's really it's good to see, and it gets statistics together, right? So you can analyse the people and out there, as you said before, you know, 15 months ago you wouldn't be able to say who's who, but now you've got a lot more grasp of what's happening, which I think is a great improvement going forward. I'm sure judge-led inquiry will bring a lot more out in depth, and until really we get the dates for that, and like I say, the scope of what's going to happen to it, there'll be more coming out of that for you to probably delve into as well. So that comes forward. I don't know quite what more information you'll probably have to come to find or help will happen. Hopefully, when we've got those dates and that inquiry's in, we'll probably go back again and give just give them a bit of an update of what's happening. But we can see there's been a lot of improvement, a lot of lessons learned, which needed to be really, wasn't it? So thank you for coming in and answering our questions this morning. Thank you very much.
Did you want us to move on to the Rampton report now, Chair?
You can do, yeah. I've got 2 recommendations.
Oh, sorry.
To go through the basics, just the feedback and members and progress of the trust response to regular feedback, and requirement outlined in the Theemis report to be noted, and let an update in respect of the transformation of crisis and community mental health care pathways be considered for inclusion in our 25-26 programme. Those members? Thank you very much. Yes, John, thank you.
Thank you very much. So, as I said originally, we came to you in January and gave you quite a thorough report about Rampton and the improvements that we've made with Rampton since in June. It was in June and July of 2023 when the CQC inspected Rampton, and the report that was then published in January 24 gave us an inadequate rating. We have had now over 18 months to put improvements in place, and we have been working tirelessly to do that. I'm really, really grateful that Dr. Gideon's come along today, because he's been at the heart of all of that as the Associate Medical Director at Rampton, and we thought it would be useful for you to hear from Trevor about the improvements that have been made. But specifically, I think last time we came, we said that we were awaiting the outcome of the relicensing process. Unfortunately, we're still waiting the outcome of the relicensing process. There've been 1 or 2 things happening nationally with the NHS over the last couple of weeks, and maybe this hasn't been top of the list, but we know that a lot of information is being gathered at the centre, a lot of data in order to inform what ultimately is a Secretary of State decision about whether to grant that relicense to us. You'll be aware that we were given a year's extension, which runs out in March of this, at the end of this month. If we are to be brought in line with the other high secure hospitals, of which there are 2, it will be a further 4-year period, because the licences are usually granted on a 5-year basis. but we don't know whether that will happen yet until we get that Secretary of State decision. So as you can imagine, it must now be very imminent, given that we're near the end of March. Alongside that, we know that CQC have been coming back into Rampton on a very regular basis. Trevor can tell you more. Over the last 18 months, including in February, we had a number of visits, and they're still, Diane's told me today, they're still asking for some more data and more information. So all of that is continuing to be gathered. I think we can't underestimate the impact that has on patients and on staff. To have people coming in continuously and looking at what's happening. But the staff have risen to the challenge incredibly well. We are very pleased to report that they have formally removed the conditions of registration restrictions that had been placed on us in terms of admissions to Rampton. So for the last year, we've had to get approval for every admission nationally. Now that is back in our own hands in terms of being able to manage that admissions process, and on the provision of British Sign Language staff. So that's a symbol of the process. I know the committee was really interested last time in what we were doing to sustain that improvement, and it's maybe a mark of that sustained improvement that they've removed that condition. It has been a tricky time since Christmas, I think it's fair to say. Trevor can give you much more detail, but a number of out of grounds patients, that is patients who have had to go to the acute hospital for treatment. And every time that patient goes to an acute hospital, we're generally talking about an escort of 6 staff. That is a very, if you only takes 3 or 4 patients to be out of grounds, and you've really decimated your staffing cadre. So that's been really tricky. And in addition to that, we had some bad weather and we've had some sickness, and it has been very tricky, but we are continuing to press on with the recruitment, and we are getting new people coming in. And one of the key areas is retention. So we've also looked at how people get a great start when they come to Rampton, and we've had a real quality improvement programme running to make sure that when we do get new recruits in, that they have that really good start and they want to stay. We also last time talked a lot about the British Sign Language, and pleased to report that all day shifts have now had that cover of British Sign Language. And when there has been, which there have been occasionally night shifts where that hasn't been available, we do now have that 24/7 interpreting service, virtual interpreting service, which has worked really well, and we've had good feedback from patients from that. And then finally, the other specialist services. I mean, Trevor works in the women's service, which is one of our national services, so can give you much more. But I just wanted to correct one thing in the paper. It talks about ensuring every East Midlands woman who is at risk of requiring secure care. Actually, this is a national service, and it is the only national women's service. But those principles there are incredibly important to us. And we have those other outreach services as well. So it's just to give you that general update. We were hoping to have some news on the relicensing chair by now, but sadly, not yet. Thank you. Jen? Don't know if Trevor wants to talk further. Yeah.
No, I mean, I think it's been a steady journey of making improvements. I think there's something around linking things up with the work that's occurring in the trust that we were speaking about earlier, and making sure that those improvements are not sort of flash in the pan improvements. There's sustainability about them as well. There's a strategy behind it, which is what we're doing.
Okay, thank you. Dr. Councillor Wilmot. Question, please, John.
I've got a number of questions, and I'll keep to questions rather than obviously, the question is on the CQC visits and outcomes. The report says that the CQC inspections were done in February 2025 to check how well the hospital is treating patients and managing itself. But it also says on page 2, paragraph 3.2, that you are still waiting for the results. Is that a concern? The second question is, given the hospital's past issues, can the report explain about what the inspections are looking for and whether the problems found before have been properly fixed yet? The fact that the results are still pending leaves uncertainty about the hospital's current situation and actions. to improve. Now, also, can I say that it says here that there's been an increase in admissions to Rampton Hospital, an increase in the number of patients needing to go out of grounds, and an increase in patients needing enhanced observation. That really proves a point that I said earlier on, that mental health is seriously on the increase in all areas, and it's an issue that must concern everybody. And it says that the staff is stretched at the present time to be able to do the work that's needed. Isn't that a concern to you also? And it also says ensuring that admissions to secure care also occurs when necessary. And how do you go about this? That's a real issue that we want to know about. Thank you very much. All questions?
Yeah, that's right.
Thank you, Councillor Wilmot.
So thank you for that question. I think in terms of the CQC coming in February, I think it's quite normal that there'll be a lag time. So I'm not surprised there's a lag between having those inspections and getting a result. So a usual sort of standard process would be that they will come and they'll do their inspections. They're with us for those 3 weeks in February. We've got quite a close relationship with the CQC now. We're coming quite frequently. But then there are often supplementary questions that they'll ask us for bits of data and information. So what they're trying to do is triangulate their information from what they've heard from patients and staff on inspection, ask us supplementary questions, ask us for data. We keep having, and as Jan was saying, we had a further request today for some more information. They'll pull all of that together before giving us a formal outcome and a formal response. In terms of the relicensing, that is an even lengthier process. So that doesn't just look at the CQC ratings. We've had input from NHS England, who come and do regular assessments and visits, from the National Oversight Group. And what they're trying to do there is again, just collaborate and see, well, what's the CQC saying? What are our specialised commissioning services seeing? What do the National Oversight Group see? And based upon all of that information, can they make a decision, which is an important one, around relicensing for the next 4 years? I thought we might have had that result sooner than now, given that we're in charge. I anticipate that we'll be getting one soon for that reason, because ultimately there's no other option. So there has to be an outcome, there has to be an answer there. Your point around mental health, preaching to the converted here, absolutely. It is a concern. I think we've seen an increased acuity and challenges that all services are facing. And what you tend to see is when there are difficulties that occur in community services, that has a knock-on effect all the way through up to high security. What we've seen in terms of our acuity is that has increased. So the people that are coming in to be admitted are facing greater challenges, are presenting with a greater need in terms of support, be that around managing risks, be that around supporting people through distress, or even indeed supporting people with their physical health care. That does place us under pressure. It's something that we are skilled at and familiar with doing. When you're at the sort of the end of the spectrum, if you like, in terms of services, we have no option to say things are too difficult, refer up. In Rampton, we have to meet that challenge. We have to rise to that challenge, and that's something that we do time and time again. The key point in that is making sure that we've got a strategy behind it, and making sure that we're looking after the well-being of our staff to ensure that we're continuing to provide that. And as we've covered already, that's something that we keep a really close eye on, and really recognise that it's important. If we didn't have our staff and if we weren't looking after our staff, we wouldn't be able to do what we do.
Thank you.
Councillor Martin, please.
Yeah, touching on the staffing issue, obviously that's a real concern, isn't it? So are you able to recruit the correct amount of staff? Because obviously the more patients you get and the more hospital visits, which is a real problem. Because I know logistically you take about 6 people each time you go. And even inside the hospital, because we went about 7 years ago, we do go on that visit for them.
I've been to Rampton.
Yeah, we went on a visit from Health Scrutiny about 7 years ago. And I never realised that each staff member has to work with another one watching all the time, you know, to me, wherever they are in the hospital. And higher up in the building you go, the worse it is. But it's a real issue. So to recruit staff and keep them, and then logistically plan, and not forgetting that it's a national service as well, because like I say, there are only 3 hospitals in the country that do what you do. You know, so it's a really interesting place, I must say. But staffing, so going forward, what is you? Can you just explain a bit more about how you are recruiting more staff?
So in terms of our staffing, so just on the point of the out of ground, so they can be up to 6. We've got some people who go out with 3 people. It's all based on the individual. But you're absolutely right in terms of we have to think about safety has to come first, and that's what on our staffing resource. In terms of our recruitment, we've had to do quite a lot of work around that. We're relatively remote and relatively isolated in terms of being able to draw on people who are willing to come to work, and particularly for such challenging work. So we've had to do we've had various media campaigns, we've had roadshow events to try and recruit, and actually some of those, particularly over the course of the last couple of months, have been quite successful. I think our vacancy gap in terms of qualified staffing now is at 3.5 full-time equivalents. Yeah. That's in terms of qualified staff. In terms of HCAs, which is a large portion of our staffing group, again, we've had a recent round of recruitment, and that continues to roll, because we need to make sure that we're not in a position that we're thinking, oh dear, we've not got enough staff, let's run out and get more people. So we've got that on a rolling basis to make sure that there's that constant throughput. And I must say, we've been, particularly with those additional efforts over the last year, we've been quite successful. The key part as well, though, is looking after our staff so that we can retain people, and retain and train the people to the standard that we need people to be.
I think just to add, Trevor, although it can be really challenging in Rampton, it's a very special hospital, isn't it? Where people do incredibly special things, and the interventions and the level of support and the engagement and relationships. As a nurse, thinking if I was a young nurse, I would find it a very attractive place to work because of that level of engagement and the support that you get from working cohesively with a team. And I think that's what we have to sell around what you can achieve as opposed to what the challenges are.
And there is nothing more rewarding than some of the work that we do there. And sometimes they feel like marginal gains, and usually sort of a series of marginal gains that lead to something that is really significant. And that's why I get to work.
And I'm not a clinician unlike Trevor and Diane, but I do volunteer at Rampton. I take my dog into the women's service, and I get a little bit of that magic that Diane's talking about, because seeing some people who've been through intense trauma, who are very, very troubled, seeing them engage with my dog, have fun, enjoy it, tell me that they're feeling calmer and happier because of it. It's incredibly rewarding. And I think getting that message across to people about how rewarding it can be to work at Rampton is very important.
I think one of the other big challenges you face is its geographical location.
Yes.
It's not really, it's like built in the middle of nowhere, isn't it?
Absolutely.
It's a major employer though for Bassett, and I think that's how we have to see it. Is it's a great employment opportunity in an area where maybe there aren't so many employment opportunities.
I suspect you're fetching people in from outside the county, sort of Lincolnshire way.
Yeah, we get people from South Yorkshire and Lincolnshire. Yeah.
Thank you. I don't think there are any further questions, so thank you again, Diane, Jan, and Dr. for coming in. I mean, as you said, I'm sure Rampton is a very special hospital and does, a very special need in our society now. Health is something that's more prevalent these days. So, I appreciate it. It'll be interesting to see what CQC comes back from its last report and findings. Now to say how proud of progress, but we can see that you're making progress, especially with the deaf people and everybody now can do the sign language, which is really good to hear. I know you specialise in that, so no, thank you again for coming in, and I can see that you're both quite very dedicated to that hospital and the work that you do, which is very pleasing to see. So thank you very much for coming in.
Thank you.
I've got two recommendations, and that is the feedback from members on the progress of the trust response to regulatory feedback and the requirement to outline us. What is this? I apologise. Am I reading the wrong page? Yeah. Anyway, and we will have hopefully come back with an update going forward when you get the security back. I'm sure it will be on included on our work programme during 25 and 26. We'll invite you back into the So thank you very much again for coming in this morning.
Thank you. Thank you.
Okay, so they've been replicated. So the recommendations, members, that the feedback of members and the update briefing regarding a national specialist certificate. Be noted. Thank you very much.
Thank you. Thanks very much.
Bye. Bye.
We move on to the work programme now, members, but I first just like to say thanks to Catherine for organising the two visits last week to Stamford Hall Rehabilitation Centre and to Bassett Law Hospital. Unfortunately, I was due to ill health, I wasn't able to attend, but I hope members did go, did enjoy it, and got a lot of benefit. I don't know if Vice Chairman will not say anything on the tour.
Particularly close to home, Bassett Law District. It's a fantastic facility, money well spent, and I'm sure Bassett Law people will benefit from it greatly.
Good. So anyway, so I thank Bassett Law and also Stamford Law for allowing us to go around, and maybe we can probably have another visit in the future, because Stamford Hall's not fully completed yet, is it?
No. No, it's not.
No. Right. So work programme. I suppose the work programme going forward will be down to the new administration after the election. So we'll remain what's on our work programme now, and then they will probably go through again. Councillor Wilmot.
Yeah, can I just say that is it possible to send an email to the ICB and the NHS for an update on the health and wellbeing provision Cabell Centre in Hong Kong, if that was possible. And also, I visit a lot of the Breathe Easy groups in Nottinghamshire, and the lung health pathway situation to consider non-cancerous pathways to follow up the targeted lung health items. Many of them would need to know exactly what the help is that there is for people with lung health issues, and so we can get that on the programmes as soon as possible, or you get just an update on the health issues that these people suffer, because they do suffer. Because and some of the meetings I go to, it's frightening.
Thank you for that, Councillor Wilmot. I'm sure they will be added to the work programme when the new administration comes into force. Councillor Eddy.
I just want to say thank you, Chairman, and thank you to the officers. As a former Vice Chair of this committee who's not standing again, I just want to say thank you very much for all your work and everything you've done, because it's a very interesting committee, and I think we do make a big difference out in Nottinghamshire. So thank you.
Thank you very much for that, Councillor. So we've got recommendations that the work programme and scrutiny criteria be noted, and that authority and be delegated to Health Scrutiny lead and update the work programme as appropriate in consultation with the Chairman, Vice Chairman, and representatives of relevant partner organisations, with any changes reported at the next meeting. So this is probably my last meeting as Chair, so I thank all members for their contribution to all the debate we've had over the last year, and we will see what happens in a month's time and see who's sitting around this table again. So with that, I will bid you all thank you for coming to the meeting, thank you for your contribution, and close the meeting. Thank you.
Thank you very much.
Thank you, Roger.
I'm sure.